Okay, good afternoon. We will be starting the session, our webinar, launching the preliminary findings of our COVID-19 survey in Somalia, the health and economic impacts. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon, good morning to those of you in the US or North America. My name is Degan Ali. I'm the Executive Director of Adeso. And Adeso is a member of a platform called Nexus, which is made up of 9 local NGOs that is trying to really provide thought leadership on the aid system in Somalia and try to give alternative ways of working that is centered around the needs of the communities in both the humanitarian development and peace building space. My colleague will share with you the website, the link to our website, so you can learn more about our work. Nexus has decided to undertake the survey. It was a collective effort. It was fully financed by the 9 local NGOs with 0 donor funding. And this is something that we're very proud of because I think it really demonstrates for us an opportunity to show that we can lead and be part of our own system and changing the system, and we lead by example and not just waiting for donor funding to take on important projects like this. So so we welcome you all to this event, and I would like to quickly introduce the panelists who have taken time out of their busy schedules today to be with us. If you will also have an opportunity to ask questions at the end, so please post your questions in the Q&A section. As participants, you'll have an opportunity to do that. Also note that the event is being live streamed on Facebook. So first, I'd like to introduce Dr. Noor Ali Mohamud, who is a human development specialist. He's the Director of Health Policy and Planning at the Ministry of Health and Human Services of the Federal Government of Somalia. And he has been serving the country for 13 years through academic, professional, and leadership positions, responding to humanitarian, resilience, development needs, and agenda of the country. Mr. Noor has a great passion to promote evidence-based and innovative solutions to poverty reduction and sustainable development goals. After Dr. Noor, we will be having the presentation of the findings led by Claire Silberg, who has been our consultant leading on the data collection exercise for us and writing the report. Claire is a global health research professional with experience developing, implementing, and managing public health research in East Africa. She received a Fulbright scholarship to Kenya, where she facilitated the US Department of State's Access Micro Scholarship Program. Claire currently works with Johns Hopkins Bloomberg School of Public Health and the Gates Institute on Global Development Projects in the areas of sexual and reproductive health, family planning, access, and gender-based violence. She has a master's in public health from Johns Hopkins. So with Claire is Laura Hammond, who's a professor of development studies at SOAS University in London. She has been conducting research on conflict, food security, migration, diaspora, and so many other issues in the Horn of Africa since the early 1990s. She's currently challenge leader in security, protracted conflict, refugees, and forced displacement for the Global Challenges Research Fund, and she's the head of the London International Development Center Migration Leadership Team. She's also the team leader of the EU Trust Fund's Research and Evidence Facility in Migration and Conflict in the Horn of Africa. Laura has many, many years of experience, practical experience working with UN and INGOs and the Red Cross in many contexts. So she's a field practitioner as well as an academic. So after Laura and Claire present the findings, we will have Ms. Hibak Mahamed, who's an infection control practitioner working at Mackenzie Health Hospital in Toronto. Hibak is a Somali-Canadian healthcare professional working as an infection control practitioner. She has a wealth of knowledge in infection prevention and control sector gained over the course of the last 8 years. She has a master's degree in public health and health systems from University of Waterloo and a bachelor's degree in kinesiology from York University. She's also a certified infection control professional with the Certification Board of Infection Control and Epidemiology. Hibak is a compassionate advocate within the sector, currently at the forefront in providing guidance and support in curtailing the spread of COVID at Mackenzie Health Hospital. And last but not least, we are very excited to have Abdulkareem Jama, who's Executive Vice President at City University of Mogadishu. Mr. Jama served in this capacity as a member of senior leadership of the university since 2012. He has a BS in Information Technology and Master's in Telecommunication Networks from George Mason University in Fairfax, Virginia. He has many years of experience in the IT sector. And before relocating to Mogadishu as the Chief of Staff and Senior Advisor to the President of Somalia in 2009. He has since served as a Cabinet Minister of Information, Post and Telecommunications in the federal government of Somalia. And since leaving office, he managed Haas Petroleum assets and operations in Somalia as a country director. He has advised the Somali government and he consults on IT and telecommunications for the World Bank and private firms. Mr. Abdulkareem Jama will also be, I'm not sure if many of you are aware, but the City University and Heritage Institute undertook a massive survey on the capacity gaps in the health system, in the health sector in Somalia, which is a very interesting report that will also be shared with you in the chat. So I think we'll now go to Dr. Noor from the Ministry of Health. And Dr. Noor, if you can please open up our session for today. Thank you.
Hey, thank you very much, Degan, and thank you everybody for joining this important webinar session, where we are presenting and discussing the findings of research related to situation and impact of COVID-19 to health and economics in Somalia. I would like to share with you some relevant information, first of all, related to COVID-19 situation and government response. I would also like to share with you the health system's capacity to respond to the public health emergencies, where we are in health systems capacity. And finally, what are the monitoring mechanism and information system to inform the decision making and response capacity to public health emergencies like COVID-19. And then I will give back to Nexus for presenting the findings. First of all, as you know, Somalia, like other countries, has been responding to COVID, and the first case of COVID-19 was found in Mogadishu in 16 March, and as of yesterday, the cases of COVID-19 is about 3,200 confirmed cases, and at least around 60 health workers have been also infected with COVID-19, and 93 reported deaths have also been recorded in our system. So the situation is improving gradually. But the federal government of Somalia, as you may be seen from the media, was the first respondent to contain and protect the virus transmission by first of all investing 5 million from the government revenue, where we started to develop of course, in collaboration with the development partners to develop a national COVID-19 preparedness and response plan. That was the first step we took as a government, and subsequently we worked with our partners to mobilize whatever resources they can get and align to responding to the national priorities for national COVID preparedness and response plan. Of course, within the national preparedness and response plan, we invested a lot in strengthening the coordination mechanisms at national level and at subnational level by establishing emergency operation centers in different federal member states. We also invested in detection and contact tracing measures, where we strengthened the surveillance systems, the contact tracing systems, where we deployed 3,000 community volunteers and community-based workers, and also established in-country laboratory capacities. First of all, in Mogadishu, Garowe, Hargeisa, and now the rest of the federal member states have laboratory systems. And also, we also invested some preventive and protective community transmission measures through risk communication and community engagement mechanisms. And other areas that we also invested is infection prevention and control mechanism, where we established many health facilities. We provided necessary equipments related to protective equipments, hygiene kits, hand washing facilities, just to ensure that the facilities are able to continue providing essential health services across the country. And as you may also know that we also invested to prevent death related to COVID-19. We invested critical care management units. Those have been established in the main towns of the country and are still being expanded to many more hospitals across the country. Now, since we have been responding to COVID-19, but maybe as you may know, our existing capacity of responding to public health emergencies is very weak. And since 1990, you know, when the government collapsed, all health systems at all levels have also collapsed. And we are very much grateful to our partners since then, both local and international organizations. Those have been supporting the life-saving interventions for the country. And you know that the government system in Somalia was reestablished in early 2000. Some of these systems were also built before that. And the government has prioritized rebuilding the systems, the health systems at all levels. And it has been the health systems has been very strengthened ever since. Particularly most health system strengthening has been made in the last decade, since 2010. In a joint evaluation that we had with UN organizations, particularly with WHO, using international health regulation, it was identified that Somalia has basic core capacities to prevent, detect, and respond to public health emergencies. But a lot of capacity gaps have also been identified within that joint external evaluation. Therefore, Ministry of Health has taken a position to rebuild and invest resilience healthcare systems by addressing key health system challenges. So our priority for the government is to build and rebuild, strengthening the health systems. And finally, I think Ministry of Health, while we have been investing in the response to COVID-19, Ministry of Health has also established a monitoring mechanism where Ministry of Health collects relevant information related to COVID-19 response from different sources, including surveillance systems. We have a strong surveillance system now. There is also information that we are collecting from laboratory tests that are being made, and also through coordination mechanisms with our partners. Whatever information we collect, we publish it through our weekly bulletins, and it is also published in the Ministry of Health website. I think you can, we will be sharing with you the Ministry of Health website to look at it, the cases that has been confirmed and where we are until now. Similarly, in addition to that, Ministry of Health has also conducted some impact monitoring assessment by starting looking at the data analysis, analyzing the data coming from the health facilities, looking at the utilization of health services. And already we observed that there is already a drop of utilization of basic health services from the health facilities. And that is an area that we also need to maybe give more attention to, so that we don't end up on reducing the utilization of health services. However, fortunately, we are also working with our partners to identify information gaps. We had particularly looking at assessing the situation of COVID-19 and its impact to community health and economics. I think the information generated by Nexus, in addition to other sources of information, will be used by all key stakeholders, particularly the state health authorities, the civil society organizations, our local partners working to respond to COVID-19. So this is an opportunity for all of us to identify any information gap that we have from the community and join our efforts to address what are the critical areas that we need to work together. So I think I'd like to conclude my presentation that I would like to call all our partners, those that are working with us, to work with the Ministry of Health and identify or share information so that we can pull together all information is available and share with our key stakeholders so that we can have a common understanding on what the situation is and how can we provide the necessary response. Having said that, maybe I will come back to whatever questions that the participants might have. But now I would like to hand over back to Degan and Nexus team to share with us the findings and the recommendations from this survey and research. And then we look forward to your discussions and questions. Thank you very much.
Thank you, Dr. Noor. That was really helpful for painting a picture of what has been happening in Somalia and also the government's response, which has been really important. So thank you for that. So now I'll ask Claire and Laura if they could present the preliminary findings and recommendations. And if the panelists want their speaking, if they could turn on their video at the time they're speaking. We're not turning on video for all the panelists because of bandwidth issues, so apologies for that.
Okay, hello everyone. Is everyone able to see the slides I just shared? Okay, great. So hi again, and welcome to the webinar. My name is Claire Silberg, and I'm the lead research consultant for the COVID in Somalia research exercise. Today, Dr. Hammond and I will be presenting the key findings from the nationally representative survey that we conducted. We will also be discussing the urgent recommendations and the actions we came up with in collaboration with the Ministry of Health, which were largely informed by the results of this study. So the pandemic has presented unprecedented challenges for the health infrastructure in Somalia and for Somali livelihoods and communities. As Dr. Nur discussed, there were many comprehensive measures taken immediately after the first confirmed case in Somalia back in March. But despite the range of responses, there is in general a lack of accessibility, for diagnostic tests. And health facilities are largely under-equipped to support the Somali population. And disease transmission patterns also often remain largely unknown. So given the urgency of the COVID crisis and the evolving nature of the pandemic, this really guided us in forming the COVID-19 in Somalia survey and research exercise. So we developed the survey to answer these 4 main questions. Our first objective was to determine the prevalence of COVID-19 symptoms since the start of the pandemic at both the national and the regional levels. Self-reported COVID-19 symptoms were used as a proxy indicator to determine the possible spread of COVID throughout Somalia and to better understand the distribution of symptoms across regions and geographic contexts. As we know, COVID is not only a respiratory illness, it can show up in unusual and nuanced ways. And our symptoms list was informed by the CDC and World Health Organization symptoms list. The second objective for the survey was to assess patterns of healthcare seeking behavior and other responses to symptoms, as well as the practice of protective health behaviors such as mask wearing and social distancing. We aim to understand what people with symptoms did after feeling ill and why. We also assessed the economic and livelihood impacts of the pandemic on people's mobility and their livelihoods thus far. Given the evolving nature of the pandemic and the prediction of multiple long-term implications of the pandemic, these findings are really just preliminary and show the impact's nature thus far on individual livelihoods. And lastly, given the fact that Somalia is a nation largely dependent on external cash flows, we are able to look at the impact of the global pandemic on Somali remittance flows. So to ensure a nationally representative survey, we employed a multi-stage cluster design to our survey, taking into consideration the population statistics at the national and regional levels, as well as the proportion of the population which resides in urban sites, rural sites, and in IDP camps. We then employed randomization at the household level to recruit participants into the survey. We developed a 50-question survey tool, which was administered by around 60 data collectors, and data collection took place between June 15th and July 3rd. So our final sample size was 4,735 participants. 55% of the participants were female and 45% were male. And we sampled participants from 36 districts across 17 of the 18 regions within Somalia. So now to present just some of the preliminary findings from these 4 sections that I discussed earlier. We found that approximately 29% of the population of adults in Somalia had at least one COVID-19 symptom between mid-March and June. The symptom assessment revealed variance in the proportion of people who exhibited COVID-19 symptoms across regions and districts. Conventionally, it is thought that the urban sites such as Mogadishu or Hargeisa are the ones with a higher proportion of people with COVID symptoms due to their large populations. However, what we found is that a greater proportion of people from rural sites actually reported these symptoms. Regions with a reported high proportion of COVID symptoms included Lower Shabelle, Bakul, and Gedo. On a national level, the greatest proportion of people with at least one COVID symptom were from Lower Shabelle region and Mogadishu. So the medical community has suggested that having 2 or more of these symptoms is highly predictive of a case. Therefore, we use this theory to guide what we determined as possible COVID cases in our survey. We asked participants how many symptoms they experienced, and 15% of Somali adults report experiencing 2 or more symptoms during this period. We also asked participants who reported experiencing 2 or more symptoms if these symptoms occurred within 14 days of each other. And we found that 5% of all people reported 2 or more symptoms occurring within 14 days. So based on this analysis, we have found that determining the prevalence of COVID-19 in Somalia, obviously we can't do that through the self-reported symptoms assessment, but these analyses suggest that there is an underdiagnosis of COVID in the communities and throughout all regions, and that the 5% of people might be cases or potential cases. So I'll talk about this a little bit more on the next slide. So this graph shows the presentation of COVID symptoms by geographic area and on a national level. So again, we determined that 5% of people experienced 2 or more symptoms at the same time. And there's not much variation across geographic areas. So in the rural sites, 6% of people reported experiencing 2 or more symptoms at once, compared to 4% in urban sites and 5% in IDP camps. So the most commonly reported symptoms were new or worsening cough and then feeling feverish. So again, because these are self-reported symptoms and we were able to diagnose COVID-19, we are not suggesting that everyone with a symptom was a COVID case or that the people with 2 or more COVID symptoms at one time are cases. We recognize that there are other illnesses such as tuberculosis, upper respiratory infections, waterborne parasitic diseases, and seasonal colds and flus, which may influence these results. So it would be wrong to assume that all symptoms are COVID cases. However, given the shortage of testing available and the high rate of people reporting 2 or more symptoms at the same time, these findings really strongly suggest a high likelihood that the prevalence is higher than what is being reported in national figures, and that there's an underdiagnosis nationally and regionally. So among individuals who reported at least one COVID-19 symptom, 11% of people reported that they had been tested for COVID-19, which represents 3% of the total survey, the total population. And as expected, a greater proportion of people with symptoms from the urban sites reported getting tested as compared to people from rural sites or IDP camps. With such a small proportion of people with COVID actually being tested, again, it's impossible to really determine the actual instance of COVID, and these individuals with symptoms may be clinical cases and infecting others. Participants who had symptoms but reported not getting tested were asked the reasons why they did not get tested or they did not seek out a COVID test. The most common responses included no testing available in close proximity. So 36% of people with symptoms reported that there was no testing available. And then 30% of people reported that they did not think their symptoms were COVID-19. And this may be due to the fact that they assumed or were diagnosed with another condition such as malaria, tuberculosis, or something else, or this may be due to the fact that individuals are not aware of of COVID-19 and the symptoms associated with COVID-19. So my colleague, Laura Hammond, will now talk about the enactment of protective health behaviors, and she will also be discussing the impact of the pandemic on Somali livelihoods.
Thanks, Claire. I should say I first joined this project as part of the peer review group, and then have got more involved in trying to go through some of the details and the findings. So unfortunately, I wasn't really involved in the data collection stage of this. But what we wanted to focus on when we look at this really rich data that's coming from this survey is try to understand, in addition to the questions about healthcare and existence of symptoms and testing rates and those kinds of things, to look at some of the wider impacts of the pandemic on the Somali society. And so So the next three kind of findings speak to that. The first is really that people feel at risk of contracting COVID-19, but they feel that they often don't have the resources to take effective protective and preventive measures. When when the survey asked them whether they agreed with the statement that they were at risk of COVID-19, 67% that they felt strongly or slightly that was the case. However, despite the fact that they know about COVID-19 and they are concerned about being at risk of it, they're, generally speaking, not able to take very much in the way of precaution to protect themselves. So about 4% reported that they were wearing face masks regularly. Just over half said that they had actually never worn a face mask. About 11% reported that they had avoided contact with people all of the time, so really engaging in social distancing and so in some cases isolation. But many people, and this will come out in the next slide as well, really felt that they were not able to afford to refrain from the kind of social interactions and economic interactions that are required to sort of make ends meet. So it's very difficult for them to avoid contact with people all the time. Most people, of course, are able to wash their hands after eating and after using the toilet. That's obviously very common, but only about 63% of households had hand soap, and the number of people who had, or the percentage of households that had hand soap was much less amongst IDP populations than amongst rural and urban populations. So when you look at these kinds of findings together, it really points to the difficulty that people find in being able to effectively protect themselves. It's not because of a lack of awareness or concern, but I think it points to the sort of economic difficulties that people find themselves within. And this will come up as a theme that runs throughout the rest of this presentation. Let me take the next slide. This is, we tried to pack quite a lot of data into this one slide, but what we wanted to show here were the different kinds of other problems that people are facing that they have to consider when they try to balance the extent to which they're able to effectively take steps to protect themselves. So, and the kind of at the bottom, when we have a breakdown between IDP, rural and urban populations, the dark blue color being the national kind of average, there's quite a level of variation in some respects. So for instance, water scarcity is clearly a much bigger problem for IDP populations than for the other groups. But generally speaking, you can see what this amounts to is really some very significant pressures on people's livelihoods in terms of being able to access adequate income, adequate money to purchase immediate food. Food insecurity is a major concern of people, and under and unemployment is also a major concern. When the survey population was asked whether they had suffered from a reduction in their available income or a increasing of under or unemployment, 66% nationally said that they had experienced increases in under and unemployment, which is really a matter of concern. The next slide. This is all, of course, taking place within with the backdrop of widespread food insecurity, and many of you who are on this webinar today will be intimately aware of some of these figures, but I thought it's worth sort of reminding ourselves of the fact that just over 2 million Somalis are estimated to be food insecure in 2020. Over 2.5 million are internally displaced or are living as refugees, and a third lack access to adequate water. So this is the COVID pandemic is adding another layer of complexity and challenge to what is already an extremely challenging year. In terms of restrictions on movement, there have been restrictions on movement, including the closure of borders between Somalia and its neighboring countries. In some cases, restrictions on movement between different places within Somali community or between Somali communities. And that's had an impact on people's ability to access markets, to access employment or labor markets or opportunities for achieving a livelihood or an income. In addition, we've seen a drop in demand for livestock exports. The Food Security and Nutrition Analysis Unit estimates between a 25 to 30% drop in this year's Eid Hajj season, which is typically the high season, of course, for livestock sales. And as we've seen, increasing unemployment and rising food prices, some of which are related to COVID and some of which are related to other factors, but all of them having a really negative impact on Somali households. All of these findings, when you take them together, really suggest that people are facing important trade-offs in terms of thinking about the extent to which they're able to take those kind of precautionary protective measures in order to reduce their chances of contracting COVID. For many cases, it really is a matter of thinking about whether or not they have secure access to food in the immediate short term of today or tomorrow versus what might happen in terms of a possible contracting of an illness in a few weeks that may or may not be a serious illness for them. These are really difficult kinds of calculations that people need to make, and it helps, I think, to explain why the level of protection that people are able to engage with is quite limited. Next slide. We finally, when we looked at this data, we were looking, there were a series of questions that related to the extent to which people are receiving remittances. As we know that remittances are a major source of income for Somali households across the country. It's estimated, there are several different surveys which suggest that as many as 40% of the Somali population receives remittance support from relatives abroad. And so we were wanting to know what's going to happen to those flows. Already we've seen that some of that support has started to wane. So we've seen that in some ways this is almost an unprecedented crisis. You have both increasing needs, cost of living, increasing unemployment within Somali communities, as well as the same crisis being felt in the sending communities. So diaspora communities, I'm here in the UK, the UK has been incredibly badly hit, as people will know, by COVID-19, and the Somali community in particular has been extremely badly hit. And so that's placed carrying responsibilities and raised expenses for families that would be sending, and in some cases they've also had a reduction in their available income. So what people on the receiving side of things said in this survey was that about half, 48%, of people who normally receive remittances said that they'd seen a significant decline in the amount of money received when they compare it to the same period a year ago. Another 39% of those who said they saw that decline said that they understood that the reason was either that the sender had less income because they were working less, fewer hours, less regularly, or because they've lost their job completely as a result of the pandemic. And this relates to some other work that I was involved in several years ago, which showed that there's a very strong reliance by most remittance recipients on a single sender. So when something happens to that single sender and they're not able to send as much or as often or even at all as they had previously, it really, the shock that's translated to the recipient is immediate and quite severe. Just next, just to finish up, we having looked at this set of findings, and we should say that this is a first brush through all of the really rich findings coming out from this survey, and we'll be working in more detail on the detailed report in the coming few weeks. But we already can see some important recommendations that are emerging. So we just take you through four sets of recommendations. The first really is around health response and the need for, in the first instance, expanding testing capacities in all regions. And Dr. Noor has really been very clear about explaining the important work that the government of Somalia has been doing to set up testing capacities in a quite rapid, quite quick period of time, short period of time. But that just really needs to be expanded and to be built upon. In addition, there's really a need for providing training to health staff in two different areas. One is in protecting themselves so that they're best able to provide care to patients, and also in recognizing and managing cases themselves. And so there's some work that's starting in that, but that really needs to be intensified. And finally, looking at trying to train and deploy community workers to identify and provide information on COVID-19, because it is an illness that people are really just not familiar with, not just would-be patients, but also health workers as well. In terms of community response, we are really wanting to focus on interventions that will have a strong likelihood of being able to be adopted quickly. So whereas you might see that restrictions on movement and sort of regulations on social distancing are really difficult for people to put into practice, it's not difficult at all for people to use soap, sanitizer, masks where they're available. And so those are the kinds of things that we think really would have more impact than an inordinate focus on constraining movement. Next slide. In terms of food and livelihood support, there's a really strong need for providing cash transfers to the poorest, particularly to improve access to food, water, essential medicines, really basic needs that are normally covered by employment or in fact by remittances. In the longer term, of course, there's a need for government to really a government-led kind of social protection system. That's not only the case inside Somali communities, but also in countries where Somalis are living. And that's a longer term goal, but it's certainly something that should be mentioned even at this early stage to help protect people from the loss of income, sudden loss of income, as we've seen in this pandemic. And the other is to help people to move safely by promoting testing in different cities, by promoting kind of safe sanitation practices and increased sanitation practices so that they're better able to protect themselves in ways that don't already take away from their existing kind of meager resource base. And finally, just looking at remittances, a couple of recommendations. The first being really to not assume that remittance recipients are going to continue to receive support, that actually some of those who once received support and now who are where that support's no longer able might be among those who need additional cash or other forms of assistance to weather this storm of the pandemic. And finally, a kind of a recommendation for remittance companies to provide discounts to senders, individuals who are sending, community diaspora groups who are raising money. I know many diaspora groups are mobilizing themselves to provide support. And so wherever possible, remittance companies should partner with them to try to help deliver cash transfers and other essential support as quickly as possible. That's the end of our kind of whistle-stop tour of this really rich data, but now we can move on to the rest of the discussion.
Thank you so much, Laura. And Claire, that was really that was an excellent presentation of the findings. We're still going through a lot of the data, as Laura mentioned. So we will be having another event once the report is finished and translated into Somali sometime in September, inshallah. So let me go to Hibak. Hibak, over to you.
Hi, everyone. My name is Hibak, as Degan mentioned. I am an infection control practitioner at Toronto. So I wanted to talk about what are our findings and what are the things that we have learned dealing with the COVID response since COVID was first identified in December. Some of the learnings that we have learned is that there is no typical presentation of COVID. Everyone presents it very differently. And because of that, we found it important that if anyone even has one symptoms of COVID, they should definitely be tested for COVID, except for those who have runny nose or nasal congestions, because they're probably due to underlying conditions of seasonal allergies or postnatal drip. We also have learned that the current evidence suggests that most transmission from symptomatic are from symptomatic people through close contacts. And that is why it's important that we abide by World Health recommendations of wearing the mask and physical distances. But there's another group of people that we've learned are individuals that shed the virus but don't actually have symptoms. So those are the asymptomatic people. So they don't actually present with any illness at all, but they are capable of shedding the virus to others and infecting others. And then there's those who are called pre-symptomatic transmissions, where they are, they have been infected with the virus, but they don't actually present with illness just yet. They're basically incubating. So one thing we discovered is before you actually present with illnesses, 48 hours before, you can actually shed the virus to others and actually affect them. And that is why we should be wearing our mask and trying to do social distancing whenever possible, because you don't really know who actually has the virus and who can actually shed it. And those group of people, the asymptomatic people, are the people who tend to not get tested. So they're walking around and transmitting the virus, but we necessarily don't know that. And that is why World Health is trying to pull all these control measures. And in Canada right now, it's mandatory that everyone wear a mask in indoor spaces, because one thing we found is COVID is easier to be transmitted indoors than outdoors. And that's why everyone now wears masks everywhere they go. And we also had discovered that most people who get COVID present with mild to moderate symptoms of around 80%. Only a few people actually have critical illnesses, which are like 5%. As most of you already know, COVID is transmitted through droplet and contact. So droplet basically means it is through respiratory secretions. So when you're talking to someone, we tend to release secretions. And if it gets into your eyes, nose, and mouth, you can be affected with COVID. But a lot of the emerging evidence suggests that COVID is predominantly transmitted to others through respiratory secretions and very through contact, meaning that when somebody's in an area and they talk, and let's say a secretion goes on an inanimate object, and then you touch that inanimate object and touch your face, then you could potentially be affected. But it's less likely through contact and is more through close proximity to another person. Another findings that we were able to learn is the period of communicability. That basically means what is the incubation period from the time that you get infected to the time you actually present symptoms. A lot of the research has showed that it is up to 14 days from the time that you've been exposed to the time that you actually show illnesses. But most people, if they do get COVID, will present symptoms within 4 to 5 days from the time that they actually got infected. One of the unique findings that we're able to discover is that there is no evidence right now for reinfection from COVID, meaning are you likely to get COVID again the second time? Because there's limited information on the immunity after infections. Like, does your body actually produce antibodies to protect you from getting it again? So because we don't know that, that's why it's important, even if you have COVID, to still abide by the World Health recommendations of the social distancing and wearing a mask, because there's no evidence now to show that you cannot get reinfected. But one thing we did discover is that some individuals can still shed the virus for up to 90 days. So, but then one thing we learned was, even if they test positive, they're not actually infecting others. It's basically a non-viable virus, meaning that it's a dead virus. So now all the hospitals are going into a non-test based approach, meaning that after 14 days, if you have 72 hours of clinical improvement, we're not going to test you to see if you're being cleared from COVID. We're just going to assume that you are, because you passed that 14 days. The only people now that we do test-based approach are the individuals who are super critically ill, like our patients in ICU or immunocompromised, because immunocompromised people tend to shed the virus longer. So that's why we'll be doing test-based approach. But for everyone else, after 14 days of getting COVID, if you're clinically getting better, then you're no longer considered infectious and you should not be tested. The last thing we looked at is, in North America, there's been a lot of theoretical information going out there saying that the Black community tends to have more COVID. Unfortunately, there's not a lot of people that collect data based on race. In Toronto, I was able to find one. It's a very small sample, to be completely transparent. But one thing we did find is COVID is disproportionately impacting the people of color, particularly the Black community. What is theorized is it's not a genetic reason as to why Black people are being more affected. It has to do more with the factors of social and economic factors and existing health disparities in the Black community. So one thing that we assume is it has to do with the Black community tend to live in denser population. So it's harder to do social distancing. So therefore you're likely to be more exposed. Also, they're considered to be essential workers, so they don't have the luxury of staying at home, which is the same problem in Somalia, where you have to actually physically go out and work to be able to provide for your family. We also have inequitable access to healthcare and social services. So one thing we're learning about the COVID is it is basically highlighting all the social disparities in the ethnic community, and that is why they're being plagued with COVID much more rapidly than the other communities. Thank you very much.
Great, thank you so much, Hibak. That's really helpful. I think now we'll go to Professor Abdulkareem Jama from City University. Abdulkareem.
Thank you, Degan. Thank you everyone for attending. Appreciate Nexus team's effort to put together this very important meeting and a discussion of its survey and the results from that survey. I also want to commend Dr. Noor and the Ministry of Health. The Somali government, as you know, stopped flights, banned the COT, and closed schools, started awareness programs as soon as the disease started showing up. There were also challenges to this measure, economic impact. We don't have the social safety net that exists in many countries, and many people had to make a living and continue despite the instructions for isolation and social distancing and so on. If you see that there were schools closed and the airports were closed, both for regional and international flights, but the mosques were full, the buses were full, the markets were full, and life was going on normal in many areas. And, we are currently looking at a messaging system. There were beliefs that why people were not following the instructions. One has to look deeper into the reasons. There were economic reasons where people couldn't just stay home. They would starve. But there were also theories that people didn't believe that anything will happen to them. This is a foreign disease. You know, whatever Allah decrees will happen, of course, but that doesn't stop us from taking precautions. And so a message that puts out if we cannot shut down for a long period of time like some countries can do, we need to take the necessary precautions if we're going to continue life as it is. The research that was conducted by City University of Mogadishu and the Heritage Institute for Policy Studies was part of a series of research projects that related with human capital development, that looked into healthcare, education, agriculture, fisheries, labor, and so on. And on the healthcare research, there were some significant findings. Again, the focus was the current condition, as well as more on the people that work in the healthcare system, the knowledge and skills that are there. It was no surprise that the healthcare services, both private and public, were ill-equipped to meet even the primary healthcare needs of the bulk of the population. Close to 16 million people, mostly young people, rapidly growing population. A lot of people rely on, whether it's because there are no alternatives available or they believe there are these, but people use traditional medicine, you know, Islamic medicine and herbalism and so on and so forth. There was a study that was cited, the World Health Organization's 2019-2023 strategy showed that some 22% of the Somali population had access to universal health coverage in 2019, only 22%. That number is supposed to grow to 33% in 2023 and to 40% in 2030, which really is, you will see how bad the situation is in terms of people accessing the most basic services that they need. Also, a study showed a discrepancy in the availability of health workers, urban versus rural. Clearly, there were more people in urban areas. There's also a discrepancy in regions. You'll find that Hirshabelle and Southwest regions had the highest shortage of health workers compared to other regions. The enabling environment was insufficient. The training that produces these doctors, nurses, and other healthcare workers is done by institutions that are substandard and unregulated. There's an absence of adequate oversight on the part of the government, and this is not something that the government's unaware of. There's a lot of private sector health that's services that are also unregulated, which could create a problem in itself. There is lack of data collection. There is no national system of health information, which would make life easier for studies like these and others, and can help in the development of sound policies. One of the biggest, the number one cause of death in 2017 actually was the respiratory infections and tuberculosis. And we know from COVID-19 symptoms that problems with the respiratory system were a serious issue. There are major shortages in technicians, anesthetics, laboratory technicians, blood transfusion, pharmacists, X-ray, imaging, people who have the right skills in all of these areas. So anywhere you look at it, there is shortage. Collectively, the universities across the country that teach, produce medical professionals, produce some 5,000 or so annually at this point. The need for the most basic coverage for the whole country will be around 90,000 people short now, which means if we produce 5,000 every year from here on, we will need until 2038 to produce that many practitioners. Many challenges, some progress. The private sector medical facilities and the professionals replaced really what used to be in the old days centralized government medical services. Now with the era of COVID-19, many schools are going, and even workplaces are going online. Telemedicine and online learning maybe will help with the access, giving students access to professionals in different disciplines who would not be available locally otherwise. There are people, to be fair, who have come back into the country, healthcare professionals who are making a difference. I know I met a gentleman, Dr. Abdulrashid Goulet in Italy, Torino before. He was the head of a cardio in a hospital. Now him and others in his hospital moved to Mogadishu and live and work in Mogadishu. And that's just one example of many people who have come back into the country. And I think as things stabilize, more people hopefully will return to help fill that gap. I want to stop there and maybe leave some room for questions later on. Thank you very much.
Thank you so much, Abdulkareem. That's really helpful, I think, to paint that picture in terms of the gaps in the capacity, the human capital gaps within the health system. Thank you all. This has been really good. I think all of you have brought different perspectives and highlighted different key issues for our discussion. We have quite a few questions that people have raised. I want to maybe go to Laura and Claire around the findings. Someone has asked about the death rates. Has there been any notable change? And Dr. Noor was saying that in the country, the reported death rate so far by the government is 93 people. And maybe you can speak to the death rate overall in relation to the data we've collected and the government data, and what kind of picture are we getting on that?
Claire, do you want to discuss those questions?
Sure, yes. So within our survey, we did ask people, while we weren't able to accurately estimate the exact death rate or the death rate associated or with COVID cases, but we asked participants if they had attended a funeral for a suspected or confirmed COVID-19 case. And what we found was that around, I think, 20% of people of the sample reported attending a funeral for someone with a suspected or confirmed COVID-19 diagnosis. but there is some limitations to that data. We recognize that in some communities, communities are small and more people, or there might be an over-reporting of funeral attendance for COVID, potential COVID death cases, and one person saying that they attended a funeral for someone in a certain community, that might be the same case as someone else's, saying that, or the same funeral that someone else is saying that they attended. So there might be, so these data aren't really super valid. It's hard to make accurate inferences from that specific data. But we added a supplemental methodology and tool to our original survey in order to kind of get more information on the patterns of deaths in major cities and hubs. So with the supplemental tool, we wanted to see, we wanted to talk to key informants, including graveyard managers and funeral directors, to see if there had been an increase or change in the number of deaths per month since the beginning of January, actually. So we were able to look at the number of deaths within each graveyard site or funeral site in the major cities before COVID, and then from March until June. And again, there's some limitations with this data as well, because we don't have information about the number of fatalities per month before January of 2020. But we were able to see that there was a significant spike in the number of deaths in Mogadishu, Bulahawa, and a few other cities as well. So we, again, were able to infer the fatality rate from our survey, but there are some, these indicators, including the funeral attendance, as well as the supplemental survey that we did with key informants, that kind of show possible increases in deaths possibly related to COVID in certain regions and areas within Somalia. So I'm happy to share more of this information with you all, but yeah, that's kind of what I have to say about that. We're still in the process, though, of really looking into the data and seeing and looking at these patterns in deaths. But yeah.
Great.
Laura,
Claire,
anything else? Mm-hmm.
Yeah, while I have you, can you also tell us a little more about the data in terms of being able to disaggregate it based on gender, age, children, disability, all of that?
Yeah, absolutely. So we are in the process of disaggregating the entire data set by educational status, employment status, age, gender, and what we are finding so far is that there isn't much variation in the health results when looking at the gender variables, or when looking at educational status. What we are seeing, though, or some of the preliminary findings that we're seeing, is that men are a little bit more likely to be practicing mask wearing and social distancing behaviors than women on a national level. And that people's employment status also affects protective health behaviors. So people who reported being informally employed, self-employed, or unemployed are significantly less likely to wear masks as compared to individuals who are formally employed. Interestingly, though, only 7% of our sample reported formal employment. So that means working full-time with a contract for a company. Most people in our sample were either reported underemployment or unemployment. So interestingly, these findings kind of show that employment status and gender are related to individuals' ability to wear or likelihood to wear masks and to practice social distancing. And in terms of disability, though, that unfortunately wasn't really taken into consideration, I think, during the design of the survey. We also were not able to look at nomadic populations in Somalia. So our survey only focused on people that lived or resided in residential dwellings or established residences in IDP camps, urban populations, and rural sites. But we did not ask questions specifically about disability. And again, some of these findings are preliminary, and it will be interesting to take a deeper dive into the disaggregation of the data.
Great, thank you so much, Claire. Now, Laura, let me ask you some questions about remittances. So question is, the money transfer companies, in terms of their cooperation and partnerships, is there a willingness on their part to extend credit to clients to spend the low on the spending side? Are there any partnerships and work between the donors, international community, to subsidize or otherwise support emergency funding, short-term loans, or forgivable debt? And then linked to that, another question is there any additional sources on the remittance drop that has been registered, not just our data, but additional other data that we can refer to as well?
Thanks, Degan. I think the answer to the first question is I'm not really sure. I think maybe there are some who are on this call who are working particularly in NGOs who've got agreements and collaborations with remittance companies who might be more able to say something about that, in which case please maybe respond in the chat box. But there are a couple of things that we should say that we've seen as a result of COVID-19. One is that in the initial stages, when lockdowns started to happen, particularly across Europe and North America, there was a significant impact because particularly amongst money transfer companies that rely on sort of bricks and mortars, what we call bricks and mortars types of retail agents to manage the sending of funding. So, you know, if you go to your money transfer company here in London, often it's in a shop. If that shop was closed, then you're unable to get in to send your money. And so there's been a shift in some cases to more online sort of digital transfers. Not all money transfer companies have the ability to do that, but those that do have seem to have be reporting increases in traffic to their websites and traffic, the monetary value of the funds that they're using, which is a good sign. It shows some resilience on the part of those who are sending, but it's also true that it's not going to be the case for everyone. Not everyone has the kind of technological kind of familiarity with such platforms, or indeed has the kind of documentation that one requires in order to be registered to use those services. So it's perhaps not a solution for everyone. The question about additional data, what additional data do we have? It's difficult to get data across the sector of all money transfer companies because, of course, that information is commercial and they're sometimes reluctant to share it with each other. But I've been speaking to a few different operators who, particularly those who do that kind of bricks and mortar type of activity, who've certainly reported drops in their traffic. But we should also say that what's happening with regard to Somali remittances is not isolated. We know that the World Bank is predicting that this year there'll be a 20% drop in remittance flows globally. And so what's happening in Somalia is very much in keeping with the kinds of predictions that the World Bank and others are putting out there. I'm sorry, I should just say that in terms of is there engagement with looking at how to safeguard and protect remittance corridors as a result of the pandemic? Yes, I believe there is. I think that DFID or the new DFID Foreign Office group here in the UK it has made it one of their priorities in terms of thinking about responses to COVID and in particular looking at East Africa. So I think it's early days though, so it's difficult to know the details of what that support is going to look like.
Thank you so much, Laura. I think I just want to let people know that there's a history of working on this issue of remittances from the time when the accounts of money transfer companies were closed in the UK and the US. I think that was in 2014. So Adeso and Oxfam have put together various reports. And we want to use this data to continuing our advocacy work. So there will be different remittance briefs that are developed as a follow-on to this research. So there will be further advocacy done on that issue with the international community, central bank in the UK, the Department of Treasury in the US, and so on. Let me get to a few other questions. We're running out of time. So Dr. Noor, a question for you is, since the first case of the COVID-19 has been reported in Somalia in March, the pandemic has silently ruined the lives of the Somali nationals who were impoverished by the conflict in the country since the 1990s. People living in Banadir and environments still in denial and do not heed to the advice from the ministry and partners. And this can be attributed to the inability of the government to provide basic amenities and information on the pandemic, mostly shared in language not familiar to the people. What is the Ministry of Health doing to ensure information is available to every citizen in the country? Dr. Noor, did you catch the question?
Sorry, Degan, maybe I lost some few minutes. If you may repeat, please.
Sure. It's a long question. Basically, since the first case of the COVID in March this year, the pandemic has silently ruined the lives of the Somali nationals who were impoverished by the conflict in the country since the 1990s. People living in Banadir and surrounding areas are still in denial and do not heed to the advice from the ministry and the partners. And this can be attributed to the inability of the government to provide basic amenities and information on the pandemic, mostly shared in language not familiar to the people. What is the Ministry of Health doing to ensure information is available to every citizen in the country?
Okay, thank you very much. I think it's a very good question. What Ministry of Health has been doing is mainly using our local partners, particularly our implementing partners providing services to the communities to provide the necessary information that are available and provided. So I think you're right, Ministry of Health doesn't have enough infrastructure, enough staff that can be deployed everywhere. So that I think the only opportunity we have, and we had in the past, is working with civil society organizations and local partners. Those are operating in the field. But when it comes to providing the necessary information, of course, we are using an information that are used globally and that's standardized across the country, and we translate it into a local language, and that's endorsed by the Ministry of Health, and we use that information and communication tools to reach out to the community. So I think when it comes to reaching to the whole population, we use different sorts of channels. One, as I said, is the local organization, and secondly is through our private and government media network. So I think, of course, we might have some challenges on reaching to the wider population, but we are doing our best to have a standardized information that can be delivered through appropriate channel and reaching to the right people on the ground. I think if you can see the findings from this study, most Back to you, Degan.
Sorry, I'm having Wi-Fi issues. I'm not gonna do a video anymore. Thank you so much, Dr. Noor. Abdulkareem, can you answer this question about this study that we've done as Nexus and the one that you and Heritage Institute did on human capital health in the health systems study, rely on quick data collection of data. Are there any recommendations based on this exercise of collecting data quickly for policymakers that could help in future data collection exercises in a crisis for policymakers like the Bureau of Statistics, Ministry of Health, etc.? And then another question is about, there's this big debate globally happening about children being able to return to school. And as academic and someone involved in the education sector, what is your views of that in light of the data that has been shared so far today? Are you a proponent of going back to normal? What are the constraints to continuing online virtual education? What impact would it have on Somali children's education attainment and so on? Over to you.
Thank you, Degan. On the first question of, sorry, the education was the second question. Let me do that first. The study was the first question. The study's findings and recommendations actually on data is very important. One of the recommendations was to create a national system for data collection. You know, the challenge facing the Somali government in all its levels is that the need for security, for political settlement, and all of that. But once we get past that, when the federal member states and the federal government cooperate and create such a system, it will be easier for policymakers, for development partners to address the challenge that people face. So this is a crucial point. The focus of our study, Heritage Institute and City University, was on the development of human capacity, but even finding out the current gaps and all of that would require a proper data collection system. So we recommended the creation of a data collection system. We also addressed significantly how to improve the training of health professionals in all levels of the system. To go to the issue of students and schools, you know, there is a serious resurgence of COVID-19 in many parts of the world. We don't know what will happen in Somalia. We just had international flights restarted 2 days ago or 3 days ago. We will have to see the impact of that on the resurgence or the lack thereof. We still are lacking in facilities and trained manpower to address these issues. If what is happening in the United States or parts of Europe, Spain, and so on, or South America happens in Somalia, Lord knows how our situation would be. So we have been very fortunate, and that needs to be studied, why the level of death and destruction. I mean, one death is one too many, but compared to what was predicted will happen in Africa if COVID-19 hits, because of the weak health infrastructure, because of the lack of facilities and doctors and so on and so forth, compared to other developed parts of the world. The expectation was that there will be a huge crisis and a lot of deaths. That didn't come to pass, fortunately, or at least it doesn't seem to be. And one has to look at why. You were asking Dr. Noor, actually there were Somali language messaging, as he mentioned, on radio and television and billboards and so on and so forth. The problem is people did not heed, in part because they couldn't afford to. They couldn't stay home because they have to make a living. Just life had to go on in some aspects. And so whether we open school or not really have to be looked at the economic impact the schools were affected, the educational system, hospitality, airlines were severely affected, especially since the rest of the country was business as usual and the markets were full and the buses were full and the masajid and everybody was everywhere without masks and so on and so forth. And so what would happen when students go back to school? The worry is that some people look at people live in cramped quarters for the most part. There are generations of grandparents and parents and children in one place. And so if the kids bring the disease and the elderly with underlying conditions and so on may suffer. If the airlines are now opening, would more people come from outside the country and bring more instances of the disease and then spread? All of these things have to be looked at. There is talk about the world going to online education at all levels, K through 12 and the university level. There are also challenges to be considered. 9% of the Somali population have access to the internet, more in the cities, big cities, and less in the rural areas. But still, internet would be a challenge to reach everybody and do an online school the way you would do in some of the other developed countries. So it's not easy to really decide to close schools because the alternative is not there, because there are economic consequences, and because the health consequences have to be studied. One has to see why we were so fortunate so that we can replicate and continue if we know why that is.
Yeah, thank you, Abdulkareem. That's really helpful. I'm going to ask this question to Hibak and Dr. Noor. Maybe you can start, Dr. Noor, which is following up on what Abdulkareem just said. As Somalis and as Somalis who are either in the public health system and you know, working either as a practitioner such as Hibak or you within the Ministry of Health, you know, we had received information come January, February, March, that there was going to be a doom and gloom scenario in Africa, and that did not happen, and it didn't happen in Somalia. And with only a 93-person death reported, and let's assume the data we have and other data may indicate a high prevalence rate of the disease, even though we don't have proper testing. I guess the question is, what is your gut telling you as a Somali that actually helped the context? You both being Somalis, what has helped the Somalis so that we don't have such a high death rate of COVID, number one? And number two, knowing what you know now, what would you do differently in March? What would be your recommendation to the government and what they should be doing? Should we have undertaken all these severe measures that have had such a horrible impact on the economy and the livelihoods and the food insecurity of the people? Would you have still recommended such measures to be taken in the country if you were to go back in time? Over to you, Dr. Noor, maybe you can start first.
Yes. Thank you very much, Degan. I think the reason why Somalia maybe is not reporting too much cases, or to be honest, and I think one reason is that we don't have adequate information that gives us the true picture. And the other reason is that, as has been said, I think we have a limited reach to the population, where we don't have adequate health workforce that can reach and record the cases, and also refer to the relevant hospitals that we have established for case management. So I think the true picture is not clear to us, but I think there are other factors that might be reasons for that. One is, I think, is the population figures for Somalia. Mainly, Somalia has is a young generation, where around 70% of the population, more than 70% of the population is have relatively less chronic cases, chronic conditions that can maybe aggravate the situation if COVID affects to them. So I think the main reason is that people may be infected, but they don't come with chronic situation, or they don't have a chronic condition that can complicate to them and reach them to the stage of death cases. So I think that is one of the reasons that might not affect, sadly, to the health to the population of Somalia. And I think similarly with other African countries. Maybe the experience to listen from the experience of Hibak. Over to you.
Hello?
Dr. Noor?
I'm sorry, I lost internet. Where did I stay last? I think
Maybe you can.
One of the reasons is because of the young.
Oh, sorry. I think we caught most of it. Maybe you can answer the second question. What would you do differently if you could go back in time? Yeah, of course, we would invest very much on community interventions. I think in our current health systems, we mainly have systems function at mid-level, where we invested a lot in providing healthcare services at the health facility level, but very limited investment have been done at the community level, where we could make a lot of impact in interventions. So I think it is too expensive for us to maybe invest in hospitals in all the regions. I think what could make more impact and could make more different is the investment of community-based interventions. And this is what we, as a government, we are now planning to make an investment and giving more attention to. Given that we are now reviewing our essential package of health services, and the delivery of the services should be more invested into the community-based interventions. Okay, great. Thank you for that. Hibak?
Hi, I agree with a lot of things that Dr. Abdullahi said, but one thing I want to mention is like Somalia's population tends to be a lot of young people. And one thing that the research has shown that a lot of younger people tend to show the illnesses much milder. Like for instance, like Italy tend to have like an older population, and a lot of them, that's why you see a lot of deaths happening in Italy. But one thing I do agree is we don't have a clear picture of what's actually happening in Somalia. And the only way we can actually get a good picture is by testing. Like South Korea did an amazing response to the COVID. They had like a COVID center where they tested everyone so that they were able to control the virus, so it wasn't as rampant. So I feel like I agree with everyone saying like we don't have a clear picture. And because Somalia has a younger population, that is why you probably don't see as much deaths compared to other countries like North America and Italy. In regards to should we still recommend these same control measures, coming from a public health lens, I would say yes, so that we can take place that it cannot stop the economy. For instance, like we can get everyone to wear a mask, and if you don't have alcohol-based hand rubs, maybe we can get access to soap and water. There's things that we can do to mitigate risk and able to support the economy. It's just being more creative for Somalia because of all of the hindrance for the control measures. But I still do feel like it's important for us to have these control measures because we don't know the long-term effects of COVID, and we do have elderly populations. So I feel like it's important that we keep everyone safe so the economy can go back to where it was.
Okay, great. Thank you so much, Hibak and Dr. Noor. That was really good. Unfortunately, we've run out of time. We have a lot more questions than we have time for, but we really appreciate everybody's engagements and interest in learning more. As we said, we're still doing a deep dive on the data, and we hope to be able to share the final report sometime in early mid-September, and along with a translation in Somali. The policy brief, the link has already been shared along with the infographics, and we'll keep you updated on all of these things and any future webinars through your emails for those of you who registered. And I want to take this opportunity to really thank all of you, the panelists as well, Claire for leading on the study for us, and Laura and Dr. Noor, Abdulkareem, Hibak, all of you. Thank you so much for taking time out of your busy schedules and being part of this and being part of the peer review group as well. So as Nexus, we really are very interested in using this data for policy and advocacy engagement with both the government, the international donor community, and civil society. So hopefully there will be more opportunities to discuss different pieces of this data around remittances, the economic impact, and so on. So thank you all for your time. We are now ending our webinar today. Assalamu alaikum.